Kaustuv Patel sir and the entire organizing committee for giving me this great opportunity to present in a hall full of thyroid oncologists, I must say. So I'm very enthusiastic, at the same time very nervous too. So in coming 10 minutes I'll be discussing mainly two important aspects. One is the data of our own institute, and later on few interesting cases related to the systemic treatment in thyroid malignancies. So we have analyzed 19 patients in which the systemic treatment in thyroid cancers were given. And if we see, out of this 19, 11 were female, 8 were male. Out of this 19, 7 were having differentiated thyroid cancers. 7 were having medullary thyroid cancers, so 7 each for medullary and differentiated, and 5 for anaplastic thyroid cancers. Out of 19, 15 had been given a systemic treatment in metastatic setting, and 4 in locally advanced setting. 63% patients had undergone molecular testing, and in this molecular testing, the most common mutation was BRAF V600E, followed by RET, and there were few very interesting mutations observed in few patients. Like in one patient we had EGFR deletion 19 mutation, which is commonly seen in lung cancer. In one case we had BRCA2 mutation. One patient had MSI high status as well. First line treatment, most common treatment was lenvatinib, followed by cabozantinib. BRAF V600E patients had received dabrafenib, trametinib. Two such patients were there. There were one patient on lenvatinib plus pembrolizumab as well. So out of 16 evaluable patients, 14 patients they had responded, the response rate of 87.5%. 3 patients were given systemic treatment in a neoadjuvant setting, and fortunately all of them had responded. Out of 3, 2 were able to undergo surgery. 1 patient had refused surgery. So in the first part of presentation, so these are some key take-home messages. MDT is the key. Response rates to TKI, it seems satisfactory. Dr. Ashish sir had beautifully mentioned a great overview about the systemic management of thyroid cancers. So yes, it works. NGS is the main backbone, send NGS. And in locally advanced cases, neoadjuvant treatment to downstage the disease helps. And as Dr. Ashish had mentioned that in guidelines we are not having this because of the lack of larger prospective trials, and probably it is very difficult to conduct such. But yes, real world evidences do play a huge role in this. Now coming to some of the interesting cases which I would like to highlight. So this is a case of a 68-year-old female. It started in 2015, the history started in 2015, where she was evaluated for swelling in neck. FNAC was colloid goiter, for which she had underwent right hemithyroidectomy outside the institute. The histopath was nodular hyperplasia, and she was kept under observation. So everything was well till December 2020, where again she got evaluated for left-sided neck swelling, and this time it was malignant. She had underwent surgery by Dr. Kaustuv Patel sir and his team, and it was a papillary carcinoma thyroid. After surgery she had received adjuvant radioactive iodine, and 2 years went well. Then again she had iodine uptake in the mediastinum, for which she again had received radioactive iodine treatment, and followed which she was kept under observation with clinical evaluation, tumor markers, and regular thyroid function testing. So it all went well till February 2025, where she was evaluated for weakness involving the left side of body with mild memory loss. An MRI brain was done, and that was having a suspicious lesion involving the left thalamic area. Iodine scan was done, and there was no uptake noted anywhere. PET-CT was done, and that showed a brain lesion along with bilateral lung lesion, and there was a lesion involving the left kidney, 29 by 22 millimeter in size. So obviously we had an MDT discussion whether we are dealing with a thyroid malignancy or a second primary in the form of renal cell carcinoma. So the biopsy from kidney lesion was done, and that was very clearly suggestive of metastatic thyroid malignancy. Her thyroglobulin also was increased from 17 to 14-19. So we are dealing with a high thyroglobulin level, normal iodine scan with PET-CT suggestive of kidney, lung and brain lesion, and biopsy suggestive of primary from thyroid origin. So this is a thyroglobulin elevated normal iodine scan syndrome or tennis syndrome, and after which the case was again discussed, and it was decided to start with lenvatinib, 8 milligram. The molecular reports were sent. Meanwhile, lenvatinib was started. It was discussed to give radiation to the brain as well as the kidney lesion. So SRS was given to the brain lesion, SBRT to the kidney lesion. Surprisingly, in the NGS, it turned out to be an exon 19 EGFR deletion mutation, which is with a very significant VAF of 31.7%. So post radiation, she was just continuing on lenvatinib because she seemed to be clinically improving. And post 3 months, her evaluation, PET-CT, MRI was done, and that was suggestive of a good response at all the sites, brain, lung. This is the lung lesion images, pre and post lenvatinib and radiation. These are the lung images which show a good response to the treatment. This is the kidney lesion which has gone down, the brain lesion. So currently she is on tablet lenvatinib and she is doing well. We had discussions about giving osimertinib, I think, which we discussed that on progression, which may be considered as an off-label use. I would like to have the insight of Dr. Ashish later on regarding this as well. So we can see this case had how many specialists involved, right from surgical oncologist, radiation oncologist, medical oncologist, endocrinologist, nuclear medicine physician, histopathologist, molecular pathologist, neurologist, physiotherapist. She needed all this for her weakness part, speech and swallowing specialist. So it required a true MDT to manage this case. Coming to second case, this case is of a 77, a very elderly female. So I just wrap it up in 2 minutes. So an elderly female, 77 years old, a lot of comorbidities, diabetic, hypertension, asthmatic, a locally advanced differentiated thyroid cancers with inoperable neck nodes. NGS was having a BRAF V600E. But there were excess issues with dabrafenib trametinib. So she was started on lenvatinib 8 milligram once a day. She had grade 1 hypertension, otherwise she tolerated it well. And she responded well to this treatment. This is a 3 months CT scan of this patient post lenvatinib. And later on surgery was possible by Kaustubh Patel sir and team. So yes, just to mention, yes, neoadjuvant TKI works, and if access is an issue, use lenvatinib, and yes, age is just a number. And this is again one case where 72-year-old female, she presented with stridor, had a locally advanced differentiated thyroid cancer, started on lenvatinib 8 milligrams. Within a week, she showed a very significant clinical improvement. And after that, she was continued on lenvatinib. Imaging revealed very significant improvement to that. She was counseled for surgery, but unfortunately, she was not willing for that. And she was continued on lenvatinib. And after 15 months, she progressed. So the point to be mentioned over is, yes, this patient had a very good response to the neoadjuvant TKI, lenvatinib. However, surgery was not done because patient was not willing for the same. But yes, it should have been done. This is case of BRAF V600E on dabrafenib trametinib, who has responded very well to the treatment. Because of lack of time, I just skipped the medullary CA thyroid case, where the patient had got a very good response to cabozantinib and later on to selpercatinib. So this is the pre and post selpercatinib images showing a very good response. So I think two important take-home messages. One is NGS and the second thing is MDT in any thyroid cancer management. And I would like to acknowledge the entire head and neck cancer team at HCG Asta Cancer Institute for giving me a great platform to perform. Greetings from the institute and thank you.